Thank you. It has been a wonderful conference or hard work of the organizers. Thank you for inviting me. My topic is a little different because like going to talk, a topic given to me is non-steroidal MRA in type 2 diabetes and CKD. So I'll be just touching about the heart failure part, but I'll try to stick to the topic given. So this is a prototype patient. This kind of patients you see every single day. It's a 62-year-old male, type 2 diagnosed, type 2 diabetes about 8 months, no other complaints, known hypertension and dyslipidemia. And if you probe, generally we do not probe, we do not spend time with the patients. That is why we miss a lot of things. And he said recently increased breathlessness on exertion. He was going for a morning walk every day for 5 kilometers. Now he's stopping after 3 kilometers, and he attributes that to his age. But 62 is not a great age. And BMI is not too bad, 30, it is, I think, 28, 29 would be the average among this crowd. BP is very good, 120/80. HbA1c is 8.1, better than the Indian standard. Indian standard is somewhere around 8.9. And LDL is still good, 92, not excellent. You heard the previous talks. It should be less than 70 being a diabetic. With multiple comorbidities, it would be even lesser. And the liver enzymes, this is important because we look at the liver enzymes and then just leave it at that. Or you do ultrasound abdomen and say fatty liver. You say everybody, including their dogs, have fatty liver. But fatty liver, it's more than that. Fibrosis is the key. And you can calculate the FIB4 score. And it does not require an elastogram. It's as good as a fibroelastogram, which is much more costlier and operator dependent. You just need 3 things: SGOT, SGPT, AST, ALT, platelet count, and age. And the FIB4 is more than 1.3, it is bad. 2.6 is very bad. So 13, 1.3, remember like that. Everybody you should make your the physician assistant or nurse or somebody calculate for each of your patients, because from a heart failure perspective, it's an indicator of HFpEF. From a patient perspective, it's an indicator of death or events. It has been shown in the MESA and other trials. And UACR, the urine albumin creatinine ratio, which we do not do routinely, is 90. Normal should be less than 30. And GFR, if you calculate, it's about 55. In a 62-year-old man, the creatinine would be roughly 1.3-ish. 1.3, 1.4 creatinine, we do not give that much credence because his TMT is negative, echo EF is 58%, EBI prime is 12, and more than 9 is abnormal. And generally what we do with this patient is we pat his back, so everything is fine, your TMT is negative, your blood pressure is extremely good, your LDL is tolerable. We send him home saying, and he goes with the idea that he's well. But he's not well. What he has is a diabetic nephropathy with proteinuria, GFR of 55, so the USCR more than 30. So this is a recent study, and 1 in 5 Indians are at risk of kidney disease. There are about maybe 40 people here, so at least 10 of us may end up with kidney disease. And the CKD prevalence of India has become nearly 16.38. It is increasing rapidly. The renal failure is increasing even more, maybe rapidly, than atherosclerotic cardiovascular disease. And we all know this slide. If you have type 2 diabetes and albuminuria and GFR less than 60, what you have to see is what is on the left side, because it's about mortality. We talk about 3-point MACE, 4-point MACE, 5-point MACE, 6-point MACE, NACE, all those things. But there's only 2 finalities. One is death, other is taxes. So look at mortality. And if a person, and this is the incidence of mortality here is 47%. This particular gentleman who looks very good, BP is okay, TMT is negative, he's at very high risk of death. Forget about anything else. Excess mortality is so much in this particular patient, and we just do not realize it. And of course, it's a heart failure meeting. We have to talk about heart failure meeting. So in type 2 diabetes with CKD, this patient who looks outwardly okay, he is at much higher risk of hospitalization for heart failure and death due to heart failure. And another very important thing which you all have to realize is even CKD patients, even patients on dialysis, majority, good number, die of cardiovascular events, that to heart failure. So that is something which you have to see. And this particular, you can see the difference, 4.7 versus 26.7%. The difference. So essentially, CKD is a cardiac disease. You've got a habit of taking over other diseases and departments, but CKD also should be considered as a cardiovascular disease. What about albuminuria? I don't know how many of us routinely do albuminuria. USCR does not cause much, and it is a very strong predictor of heart and kidney disease outcomes. And the USCR goes more than 30, it's a harbinger. It's like you can say that this particular person has or will develop or will die of cardiac or renal disease. And if you reduce by any means the albuminuria, you reduce the risk of cardiovascular mortality. And again, I love talking about mortality because I hate talking about 5-point or 6-point MACE because that is very convenient, and even I don't personally like the KCCQ or the quality of life because it's very, very subjective. Mortality is not subjective. You are dead, you are dead. So then you reduce mortality. You reduce albumin, you reduce mortality. But do we do that? That is the question. And all guidelines very clearly says that annually, we are cardiologists, but we see most of our patients are diabetics. So we have to be responsible for the patient. So what is the recommendation? Annually, we have to do the GFR and USCR. GFR, now many people calculate, but USCR is the Achilles heel. We do not do that. And by doing that, it is an act of omission which may lead on to a higher mortality of the patient. Now coming to what happens in diabetes. And diabetes, what happens is the mineralocorticoid receptor in the kidney becomes abnormal. And this adds on to inflammation and fibrosis. We heard a lot of talks about inflammation. And this inflammation fibrosis leads on to especially HFpEF. And the therapies we had age-old therapies, RAS inhibitors, and IDNT, renal. The interesting thing about IDNT renal was that renal endpoints reduced. It did not reduce mortality. So that is something which you have to keep in mind. When the nephrologists are very fond of that, but what are the drugs which reduce mortality? They are SGLT2 inhibitors and finerenone. So in this particular patient, who we see that, we think that it is a relatively benign case, you should treat the patient holistically. Now GLP-1 receptor agonist also has come. And the residual risk is tremendous. And you can see the residual risk keep on increasing. And if you see in Emperor reduced, the residual risk at nearly 3 years was more than 30%. It keeps on increasing. So we have to tackle that. So that's where finerenone comes. I think there were talks about finerenone before. So it's a bulky, non-steroidal, very potent against mineralocorticoid receptor, very selective, no CNS penetration, practically no hormonal effect, and shorter half-life. So there's a huge number of trials. And being cardiology, heart failure meeting, on my right, that's your left, you see all the heart failure trials, including the fine arts, which is a seminal trial because that trial showed that the MRAs, non-steroidal MRAs, can be useful in HFpEF. And on your right and my left, it should be CKD with type 2 diabetes. You see the trials in various forms. So I will just mention about fine arts and Fidelio Figaro. Essentially, Fidelio Figaro were diabetic kidney disease trials. So just like our patient. It is not a heart, but believe me, our patient has got HFpEF because he has got multiple criteria of HFpEF, even if there is no NT-proBNP. If you take the HFpEF score, it will be high. So, but I'll be going into the Fidelio Figaro part. Essentially, Fidelio-Figaro were people with diabetic kidney disease. One study looked at the cardiac endpoints as primary endpoint and renal as a secondary. Another study looked at the renal endpoints as primary endpoint and cardiac endpoint as secondary. And the exclusion was potassium more than 4.8, but in fine arts, which is a heart failure with preserved ejection fraction trial, you can see here there's not even diabetes there in the inclusion criteria. So it was fine. But our patient fits into both categories of fine arts as well as Fidelio-Figaro. And you can see there is a significant reduction in both the cardiac endpoint as well as the renal endpoint. And this is important because for us, about 25% reduction in heart failure hospitalization. And again, back to USCR, the things which cardiologists do not look much, what they found was that the USCR was reduced by about 32%. That is a big number because 30% seems to be a magic number. Because if you reduce by 30% albuminuria, you reduce CKD progression. So 30% is what we look for. And in Fidelity is a combination of Figaro and Fidelio. Both were combined pre-specified. And it reduced kidney outcomes by 23% and end-stage kidney disease by 20%. So this was the key thing in Fidelity. 22% reduced risk of first heart failure hospitalization and 32% reduced risk of new onset heart failure. So that is why ESC 2023, ESC is our guideline. So they said in patients with CKD and type 2 diabetes, it is a class 1A indication. That is as strong as the indication can be. So again, to retrospect, how many of us do look at USCR, how many of us give the medication. Then like the Finerenone again showed EGFR, the EGFR decline was slowed and even patients with stage 4 CKD. So stage 4 CKD is a no man's zone for the cardiologist, but still we can use that and it reduced urine albumin creatinine ratio significantly. So there is still effect on nearly end stage patients. Then this is the very recent trial where you when you combine both SGLT2 inhibitors and Finerenone and what happens. And that is an interesting study because the combination was tried against empagliflozin and Finerenone individually as a 2x2. And you can see when you combine, USCR reduces by a whopping 52%. That is a tremendous benefit. What about the side effects? Side effects were, they were there, but the clinical impact was very minimal. The hyperkalemia leading to permanent discontinuation was 0.6% in placebo versus 1.7% in the Finerenone group. That's a very low number. And hyperkalemia leading to death was 0 in both patients. So, and this was not associated with serious kidney-related adverse events. So that is something which, and the blood pressure reduction was about 6 by combining. So where do we stand now? Mineralocorticoid receptor overactivation leads to inflammation, fibrosis, and this is a very bad thing in diabetic with kidney disease. Finerenone, a novel non-steroidal selective MRA, blocks MR overactivation and reduces albuminuria. And it is different from the available MRAs, including spironolactone. And Fidelity and the confidence showed that there is not only renal benefit, but also significant reduction in USCR and cardiovascular benefits that and heart failure hospitalization is reduced by about 25%. And finally, we have 4 pillars in HFrEF. This is a heart failure meeting. So we have to talk about the 4 pillars, but here in CKD and diabetes. And RAS inhibitors, of course, SGLT2 inhibitor, Finerenone, class 1A, SGLT2 1A, and GLP-1 is also coming in a big way. But the question is, we always see, every day we see patients like this, with proteinuria, if you check, and are we giving these medications? And again, there's a famous heart failure Muthuwada's paper, what is the benefit when you combine. And this is about renal endpoints. When you combine them, what you gain is the more than 7 years without heart failure hospitalization, 2 years from death, so we saved 2 years, kidney failure from dialysis about 4.9 years. So this is the benefit of combining all three. It is not GLP-1. When do you add? So do you add everything slowly, step by step? Answer is no. Now we have to rapid, like strong HF here, we have to rapid inclusion of all the 3 or 4 drugs. So I conclude by quoting Milton Packard. It does not matter how many trials we do, it does not matter how many guidelines people write, or how many presentations we give at national or international meetings, or how many meetings we attend or present, if physicians are not prescribing these drugs. So this is something which we had to ponder about. And ladies and gentlemen, thank you very much for patient hearing.